Hi, and welcome back to JNO Network Open Live. I'm Seth Truger, Digital Media Editor at JNO Network Open.
And I'm Angel Desai. I'm the Jama Fishbein Fellow.
Of course, if you're following along live, please send us comments or questions through Twitter. You can just reply to us at JNO Network Open or on Facebook or YouTube in the comments. So first up, we've got the concordance between electronic clinical documentation and physician observed behavior by Carl Berdahl and colleagues. So Dr. Berdahl, welcome.
Hi, thanks for having me.
So why don't you kick things off? Tell us a little bit about Tell us a little bit about yourself and what you did here in the study.
So I'm an emergency physician and health services researcher. Just finished a fellowship in the UCLA National Clinician Scholars Program a year ago, at which time I did this study with my colleagues. The study was inspired by times on shift when I've been reading other physicians' notes and thinking, they really documented a very extensive exam and history, but I'm sort of skeptical that in the emergency department setting that they're really spending that much time at the bedside. So the objective of the study was to quantify the accuracy of physician documentation, particularly in two areas of the chart that are pivotal to billing, so the review of systems and the physical examination. What we did was an observational case series in which we had trained observers shadowing emergency medicine residents that were senior in terms of their level of training. The residents initially were not told exactly what we were doing in the study. They were told that we were determining, how they were doing their histories and physical examination, but we did not tell them that we were examining their documentation. So we shadowed in our final cohort. We had 9 physicians in a total of 180 encounters, and we found that there was accuracy of about 38.5% in the review of systems and 53.2% in the physical examination. Interestingly, we did a small relevance analysis where we looked to see, are these important things that are being thrown into the chart, or are these perhaps things that are less important? And so, for example, patients who came in with a GI or GU complaint, in terms of the GI or GU examination that was documented, there was only 5% unsubstantiated documentation. Whereas for the ENT examination, that was unsubstantiated in about 82% of cases. Overall, our conclusion was that there are inconsistencies in documentation, and really the goal of this study is to influence policy, and hopefully CMS and other payers will listen and think that maybe it's time to reform the rules and regulations that we practice under.
Yeah, I mean, when I first read this, and I'm an ER doc as well, my first thought is, well, this is kind of an open secret. We all know that we're all kind of doing this to some extent. I feel like ethically, I felt a little bad about, the kind of what standard behavior is, and took some time to make sure that my standard templates are things that what you guys called unverifiable, like looking at work of breathing and not listening to lungs. And you're always looking at work of breathing. You're always looking for,
Exactly.
Like that, which is nice, but it's hard, and you can't get to level 5 exam without actually doing stuff. I tried pretty hard, and you can't do it. I think this is one of those open secrets that we all know about. I think it's Jerry Hoffman, who you probably are familiar with, who said, the review of systems turned us all into liars.
Yeah, that's an interesting comment. And so I definitely hope that this is able to push policy in a new direction. And so actually, CMS did release a rule recently looking at office-based visits, so not in emergency medicine, but in office-based visits, that in 2021 they may require only a sort of medically necessary examination and also review of systems documentation.
Yeah, and that's nice kind of to move things forward. I mean, the flip side is, I'm a little skeptical. Does that mean it's just going to be easier to upcode encounters as far as the complexity in medical decision making and risk to the patients if you don't have to do the other stuff? But documentation for the sake of being a burden by itself is probably not great. One of my favorite parts of the study is if you look at Figure 2, the scatter plots, where you kind of show the what was actually done or what was documented on the x-axis and what was actually done on the y-axis, and there's a big cluster of dots at 14 systems because most people are checking review a system, all review systems, reviewed in negative.
Yes, exactly. And so there are 3 panels of that figure. The middle panel actually ignores that attestation of all other ROS negative, and so you see a kind of a more normal distribution in terms of the shape of where people's behavior is lying, but it doesn't actually improve the accuracy very much to ignore that attestation, as we saw.
Yeah. Yeah. So I mean, this is nice stuff. Again, it's a little potentially embarrassing stuff for us. There's, I guess we probably, I don't know. We want to be ethically correct. We want to, only document things that we've done, but it's also, should we be, asking people about things that are irrelevant, wasting our time just to buff the chart, basically.
Yeah, one debate that we had was about how much blowback this paper might have on the specialty of emergency medicine in particular. And it's interesting you mentioned this term open secret, because when I did a presentation of preliminary findings during a job talk, actually, one person stood up and said, well, this is an open secret. Why would you even publish this study? We all know that it happens, and it's not just a problem in emergency medicine. It's really across the board.
Right.
Yeah.
Yeah, definitely. I will say, as the non-ER person here, it's definitely an issue. And I appreciated about how you mentioned that auto-population of templates may be part of the issue. I know I've seen that outside of the ER, but I don't know if you can speak to that a little bit more too.
Yeah, so one of the things that we tried to do in the study was to actually look at where the text was coming from in terms of how it was created. Unfortunately, we didn't have the capability. Epic introduced a new build, which makes it possible to look back in time and see where parts of the history and parts of the physical examination came from. But that was only introduced sort of near the tail end of our study, so we weren't able to do any sort of significant analysis with that. But what I will say is that anecdotally, we didn't do an extensive analysis of this, but I looked at all these charts myself, and each physician seemed to have a template that they were using, not just at one, but both sites, and that they were editing sort of in the most pertinent areas of the history and physical examination. So I do think that the pre-populated text is a significant issue here.
Yeah, absolutely. I remember a few weeks ago, a resident was doing an M&M presentation and got to the physical exam, and then showed a slide of what was actually pre-populated versus what was actually documented, and it's it can be shocking. That being said, this doesn't mean that if you're using templates or macros that is bad. It's that you have to be deliberate. You have to go back and check what you actually did. I actually give our charting talk to our residents when they come in, and a big part of it is you got to use this stuff to be efficient, but you have to be responsible about it. I'm not going to pretend that everybody does. I go back and look at stuff occasionally, and there's room for improvement, I would say politely.
Oh, yes. And even in my own charting, too, I had the experience of testifying in a court case recently, and my chart wasn't consistent. And I wrote in the HPI that the patient had used some illegal substances, and then there was a pre-checked box that said, no drugs. And so, there I was on the stand, and they were like, "Doctor, what do you really mean?" and I'm like, well, you got to trust what I hand wrote, that's we as physicians know that the handwriting, is or dictating is going to be a little more accurate than what's pre-populated. But I think that the average sort of regulatory person may not realize that this is going on to such an extent as it is.
And it's kind of hard too, because some of the auto-populated text, it's actually very difficult to delete if you try to go in and do it. So I think that just adds another layer of difficulty to the whole thing.
Yeah, it certainly depends which EHR you're using as well. I've used Cerner in the past, and you can write an entire pre-completed note in Cerner where it literally, like, the entire note is ready to go. So, for instance, I did use that some for evaluating like a pediatric URI, and I would write in the HPI, but then basically the rest of the chart was done. And so, it certainly can save time, but the real question is, what are we doing here, and what is best in the interest of patient safety? So one of the things that our group is doing moving forward is we're looking at new ways to document, but we hope that the policy will be relaxed to sort of allow us to experiment. But we're interested in doing things such as having patients write their own history while they're in the waiting room. Like, let's say a patient's waiting to be seen for 3 or 4 hours, they might as well be doing something that's going to aid in the communication, perhaps aid in patient engagement, and also improve communication between the patient and the physician. So that's one thing, and the other is to look at ways to do passive documentation. So, for example, in court cases, they use transcripts, and that's sort of the living document that they base a lot of the foundation of the decision making. And so, what we're wondering is if we could have audio, video, or a transcript derived from audio and video as the living document, and then have the physician write a medical decision-making note. I mean, I think that we always need to be explaining our reasoning, as that's really probably the most important reason to have physician documentation. But in terms of what transpired during the encounter, I certainly see a lot of room for sort of passive documentation to change the way we do things.
Yeah, the court transcript model certainly makes some sense. I worked with scribes a little bit previously, and what I've tried to do is, it's like, oh, your belly doesn't seem tender at all, and you're not distended. Or distended
Yeah.
in real time. It's never that efficient, and I primarily work with residents, so I don't have to do a lot of that documentation most of the time, which is nice.
Yeah.
I've certainly heard about outpatient offices doing like the review systems on, the patients do it in the clipboard in the waiting room, which makes sense. Of course, you run into the same potential pitfalls of, are people actually checking that? Are people just, clicking the box of, yep, it's reviewed and done? I'm optimistic that Medicare, that CMS did release the new rules for the outpatient billing, that these requirements aren't going to be as stringent, which is nice. So the ball's certainly moving in the right direction. But also on the flip side is there's so many big fish to fry.
Yeah, I agree. But I do think that, there's so much literature out there about physician burnout, and a lot of that I do think can be attributed to the documentation burden. And so, currently CMS does have, I think they're calling it a campaign called Patients Over Paperwork. And so really they are looking at issues like this and trying to see what ways technology can help us move forward. So that's pretty exciting. And actually, in case some of the listeners out there are policy wonks like me, the relevant proposed rule still has a comment period through, I believe it's September 29th. So if anybody wants to submit comments about how documentation regulations could be transformed, then you can go to the CMS website and submit a comment.
Yeah, I'll throw in a plug for that. And I've done it before. It's actually pretty easy, and they actually do read them and they do care about them. And if nothing else, it gets in the Federal Registry later on.
That's great.
So.
Yeah.
One of those things is surprisingly easy to do. Well, thank you so much for joining us. Really interesting paper. This is just nice stuff, and hopefully will help move things forward and make our lives a little easier, so we can take better care of patients.
Awesome. Thank you for having me.
Great. All right, we've got a couple new people joining us. We've got R. Bergmed and Ilya Averes, who joined us on Periscope. Thank you. Welcome. We are moving on to our next paper, another EHR paper. Fun stuff. So the effect of an electronic medical reconciliation intervention on adverse drug events and cluster RCT from Drs. Robin Tamblin and colleagues. So this is a really interesting one. This is less directly in the EMR. But at McGill, they took 4 units, 2 medical and 2 surgical units, and randomized them to use a basically automated computerized electronic medication or MedRec software instead of the kind of typical usual care of either pharmacists or nurses or docs looking up the medications, or they're actually calling pharmacies and getting the pharmacies to fax the information, which is the one of the fun things. They got 4,700 patients, which is pretty impressive. The good news is that there were fewer medication discrepancies, which is nice. The bad news is there were no differences in any actual outcomes for patients.
Yeah.
So no difference in adverse drug events, no difference in ED visits after or what else was hospital readmission, any of that kind of stuff, which is too bad.
Yeah, I mean, I think it's great that they were at least able to reduce the amount of discrepancies because it is important.
Sure.
I think overall they found that there were something like 4%. There was a 4% sort of prevalence of actual adverse drug events in the whole population. So fairly low, but the other thing that I sort of appreciated is that they mentioned that there were some differences in terms of patients that had a lot of medications or a lot of comorbidities that really added another layer of complexity. So I think that's important, in terms of thinking of targeted interventions for different populations.
Right. Yeah, I mean, if nothing else, this makes a lot of sense as far as it's certainly a much more valuable use of time to kind of approve what's coming from, especially in Canada where they got the provincial database. The computers connect to the other computers. Here's a list. Are they still taking yes, no, and click down versus actually calling a pharmacy to have them fax stuff over to see if it's correct or not. There's plenty of other work that we could be doing and better ways we can spend our time. It's also interesting that there was, what does it say? That there was an association where there were more they found that when they changed prescriptions or added new prescriptions at the end of the hospital visit, they're more likely to have an adverse drug event. So that stuff is relevant, and that's stuff we need to pay attention to. But most of the regulatory stuff, most of the hospital accreditation bodies, they focus on med-recs, especially at the time of admission, and that just doesn't seem to be where the money is.
No, definitely, and I'm just thinking back on to my time on the wards, and certainly when there are patients that came in with some sort of acute issue, and then you completely change around their medications. That's a huge issue, particularly in terms of just making sure that whatever gets printed out for them, that they understand and that it's sort of concordant. So it seems like a nice intervention.
Yeah. Absolutely. And again, we're all so busy in the hospital. This is medical professionals' time doing important things or less important things. And especially kind of like what we were talking about in the last paper, how much work is being done to meet certain requirements by the payers or accrediting bodies. So let's make better rules for everybody.
Definitely.
Ideally. But we'll see.
I don't know if this is what.
It's metaphorical, but right? Right. Yeah. All right. So moving on to our table of contents, we've got a whole bunch of papers. First up, there's interesting paper. We had talked about a similar topic a few months ago with Mike, but they did for partial robotic-assisted partial nephrectomies. They randomized patients who were getting these done by 11 different surgeons to have, instead of the traditional axial imaging like typical CT or MRI imaging, to actually make 3D models that they could look at on their iPhones, and then actually made VR models, so actual virtual reality. They could put on a virtual reality headset and look around. And I'm not sure what to make of the results, because in the unadjusted outcomes, there were no differences in any of the outcomes. The operative time, the clamp time, the estimated blood loss, the hospital length of stay were all very similar. When they adjusted them, kind of doing the routine stuff, they were more likely to, the usual care group was more likely to have a greater than 2-day length of stay or excessive estimated blood loss. But then they did some, these estimated ORs.
Yeah, it wasn't.
Where they kind of did even like super adjustments based on the, what do they call that? The nephrometry scores, which is an assessment of complexity. And they basically said, if you actually do all this overcorrection, then, or this loss of correction, then using the tumor's radius, the endophyticity, and some other stuff, like where the vessels are and stuff, they were able to find even bigger differences. But
I also was wondering, because these were all surgeons that I assume have a lot of experience, or have. I don't think it was clear exactly sort of the levels of experience, but I do wonder about having virtual reality, particularly for people that are trainees, because I think the more sort of experience you can get in whatever form may be beneficial. But even still, I thought it was interesting, and they looked at, I think, 92 patients. They looked over 6 teaching hospitals, so a pretty wide variety of places and people.
Yeah, and to kind of build on that point, we've seen a lot of that with the data for direct laryngoscopy versus video laryngoscopy for intubation, and that the experts who've been doing DL for decades, there's really no incremental difference to doing video laryngoscopy. But for training people to get them up to speed, there almost certainly is a difference, and there probably do end up being some longer-term outcome differences. So it certainly makes sense, especially if the technology is not too expensive, not too burdensome. It certainly, again, there's opportunity cost to everything. So if it's easier to train people on newer technology, as long as the costs aren't that much, it makes sense.
And I think a lot of training programs and medical schools are sort of moving towards that model in terms of introducing more simulation labs and just different experiences to get trainees more comfortable, at least. Right.
And just a reminder that a lot of the stuff we do, we do it because it's the way we've always done it.
Because
it's a good way to do it. But yeah, there was a resident I used to work with who would, he'd look through a CAT scan on the axial images, the kind of the standard way. Then he switched to the coronals and called them the cheating images. So everything's a lot easier that way. So.
Yeah, it's true.
All right, so moving on. Next up, variation in the assessment of immune-related adverse event occurrence grade and timing in patients receiving immune checkpoint inhibitors. This paper is interesting. They looked at immune-related adverse events for immune checkpoint inhibitors in patients, in these 52 patients getting care at NCI comprehensive cancer centers. What was most interesting to me about this is well out of my clinical wheelhouse, is that they had 2 observers trying to grade whether or not the patient's clinical outcomes were adverse events due to these chemotherapy agents, and they were using pretty decent standard. They were based on the common terminology criteria for adverse events, version 5.0. You know, this is, you know, these are the stuff where, you know, there's very clear criteria, and the kappas on agreement were terrible.
Right.
It's like 0.4 to 0.6, which is really not good.
Low.
And it's even with good standards, with one exception, which was hypothyroidism, where the kappa was 0.8, but that's probably almost, you know, very basic lab testing stuff and not.
Right. And I think the authors even mentioned, and I think it makes sense too, that a lot of these sort of criteria that they're looking at, or outcomes that they're looking at, really don't necessarily have a good clinical marker per se. It's sort of a, you know, you come to that decision or that diagnosis using a variety of markers in the clinical picture. So in one sense, it makes sense. Right. On the other hand, it's tricky because I think we're seeing the use of these agents more and more often. And so certainly coming to some sort of standardized criteria would be helpful.
Right. But even with these relatively standardized criteria, the observers,
no, that's true. That's true.
Yeah, I mean, for me, a lot of it's the more I see, you know, this kind of like, I don't know, pseudoscientific, no, I don't want to call it pseudoscience, but pseudoscientific approaches to make things that are subjective into allegedly objective. It just doesn't, you know, totally turn subjective things into objective things. And, you know, a checklist on stuff, there's still a lot of interpretation for everything. You can split a lot of hairs and get really pedantic about stuff.
Yeah, that's true.
Yeah,
that's true.
All right. Next up, another one on assessments in cancer. So these authors looked at they evaluated continuous tumor size based endpoints to see how they worked as surrogates in metastatic colorectal cancer RCTs. So they pooled 20 different RCTs on metastatic colorectal cancer. They looked at how chemotherapy, anti-angiogenic agents, and anti-epidermal growth factor agents worked with this. And basically the idea is that, especially with colorectal cancer, where a lot of people are getting diagnosed early based on colonoscopy and you know, getting polyps with pathology, and basically very early on, you can have, it's pretty hard to get to hard objective outcomes like overall survival. So trying to find useful surrogates makes a lot of sense as far as you know, resources in trying to get research funding and try to prove, you know, that new drugs work, et cetera. And unfortunately, they just found that this didn't work as a, you know, despite being promising, that getting tumor size down, either based on the time to when they got to the nadir or the trough of the graph, or how deep the depth was, just really correlated pretty terribly with overall survival.
Yeah, and I think that they did this using regression, and you know, they were using the coefficient, the R squared, and so certainly using that alone, there's some challenges with that both ways, but definitely the R squareds were pretty poor across the board. So that's unfortunate.
Yeah, and they described an R squared of 0.75 as good, which is, again, we can debate this kind of stuff, but that's still a pretty reasonable threshold. The highest one they got was 0.63.
Yeah.
And these are pretty big studies. You know, they had 14 chemo trials with 4,300 patients, 11 anti-angiogenic agents with 4,800 patients, and 8 of the anti-epidermal growth factor trials, 2,700 patients. And the R squares basically varied from like 0.2 to the highest is 0.6, or actually the lowest is 0.06.
0.06, yeah.
So big difference is when you look at the actual plots, you know, you can see like there's just dots all over the place with a line kind of somewhere in the middle.
Yeah, yeah. And I was interested that it really didn't. It didn't matter sort of what type of treatment it was across the board, that this was an issue.
Yeah, so I certainly understand, you know, the desire to try to find surrogates, so you don't have to follow people out for years and years and years to show that something works. The problem is that this doesn't seem to work, and that there's so many different ways, like we're talking about, in classifying how things work or don't work, that it just doesn't work out.
Search continues.
Yeah, we've got a comment on Facebook. Ilya Seleznev says, pharmacies can also do more to help the patient organize multiple medications. Yeah, so absolutely. So that's one of the other problems, especially patients with polypharmacy.
Yes.
Going back to that paper we were talking about before, the way that the lists come out can be pretty disorganized. I don't remember the details. This software that they use for the electronic MedRec actually did that to some degree.
Yeah, I think that they organize it based off of sort of complaint or diagnosis.
System or class.
Which I actually loved. I thought that made a lot of sense intuitively, because even if it's alphabetical, you know, you're searching through all these paper lists, it can be pretty challenging. So definitely one way to help us along.
Right, absolutely. Yeah. Yeah, and also figuring out standards for those can be helpful. So what are routine ways that we do it, or our hospital software that can put it where it's like chief complaint related or diagnosis related or not. Yep. All right, next up, another one that I know very little about, the association of tumor protein P53 and Ataxia-Telangiectasia mutated Comutation with response to immune checkpoint inhibitors and mortality in patients with non-small cell lung cancer. Basically, we were joking about this before. This is the first time I'm saying P53 unironically since probably taking step 2.
Yep.
This is just not what I work on. But basically, they found that in some patients with non-small cell lung cancer, there are patients who have both P53 and Ataxia-Telangiectasia mutations. And when they have both of those, they respond to immune checkpoint inhibitors differently. So this is a promising area to try to identify, basically patient-specific, gene-directed, targeted therapy.
Yeah, and I think again, always looking out for some sort of new biomarker or biomarkers is always useful. And the immune checkpoint inhibitors come back again.
They're so hot right now.
They are. It's true. It's true. I was surprised at actually how low the percentages were, the prevalence were of both of these gene mutations. I think it had the co-mutation 3.6% in one of the databases and 2.6% in the other one. So not necessarily widely generalizable, but still useful.
Yeah, it was also interesting to me. It looked like these weren't very specific gene mutations. There were like a bunch of different, different locations that had mutations. Again, this is well out of my expertise, but it certainly speaks to this. This might be more about sporadic rather than genetic mutations, or that the genes to this are again just more complicated, or it's not just I have a family history of cancer. So there's all these different histories that can go into it.
Yeah.
But again, when we get these big therapies, I think precision medicine might be a little far off into the future, but the idea that there's still ways we can figure out when we have new advances in therapies, figuring out the right patients who they can benefit instead of saying, oh, nope, didn't work for this big population or did. Yeah. A couple more people joined us. We got Husam247 and Leaderloo8 are joined us on Twitter, so welcome.
Hi.
We've got our last paper for the day. This is the effect of the iExaminer teaching method on fundus examination skills. This is a really cool little RCT research letter where they randomized 115 students to a handful of instructors using basically just the standard, not the standard ophthalmoscope, but the Panopticon, the big one that kind of looks like a surveyor's tool, where you get a pretty decent view of the fundus without dilating the patient. Versus using this iExaminer, which is cleverly named, which a lot of the Apple type stuff works out well for ophtho stuff just for the naming. I have an iChart app on my phone.
I think I just got that. Like it.
Yep. And basically, it's this essentially an iPhone case that hooks up to the Panopticon and lines it up with your phone's camera, so then you can actually see it on the screen. And basically the idea is instead of trying to look through the screen and describe what you see to the person who's teaching you, they can look at the screen and see the findings as well. And it just is one of those things where they did find slight improvements here. They improved from 30% accuracy in the control group to 47% accuracy.
Yeah, that's
which
pretty good.
Still that's a big improvement, still not great. And it shaved off 6 seconds or nearly 10% in identifying the finding.
I think it's great because we were talking before, I remember in medical school learning this exam or learning how to use these tools and how to do a basic ophthalmic exam. I think we only had 1 week in which we learned this, and it was sort of med students looking into each other's eyes and thinking that we may see something. So this at least is useful from a trainee perspective to get some sort of feedback to know what you're looking at and to help with that.
Yeah, and again, to make the analogy with direct laryngoscopy versus video laryngoscopy, which I have a lot more experience with, as a teacher, as an instructor with this sort of stuff, it's so much easier to give the trainees kind of more time to figure things out if you can actually see what they're seeing. Yeah. As opposed to like, what do you see right now? What do you see right now? What do you see right now? Is it, if I can see it on the screen, I've got a lot of information. Oh, they're close, or they're going to get it, or things are going to be okay, or oh wow, they're totally off base, and we can help move things along. Unfortunately, the logistics aren't great. I just looked quickly online to get the whole kit, so the entire ophthalmoscope with the Panoptic in the case is around retails in the $800 range. The Panoptic heads themselves are like $300 to $400 and maybe up to $600. The case itself, the actual adapter, it looks like they're somewhere between $30 and $90 depending where you get them. But then there's also the problem where like the new iPhones just came out last week, and is it gonna have the same form factor, and is the camera gonna line up to it? And if you have this, how soon is it gonna be obsolete?
Yeah, so a little pricey, but you know what? Education is priceless.
Yeah. Right. No, that's true, and it's also if I would say as an individual, it's probably not worth doing unless you're doing a ton of fundoscopic exam. But if you're in a teaching environment, getting a $100 case to go on your pen outfit that you already have to teach students, for years, and especially if it's an iPhone that doesn't need to do anything else and just sits there in your ophthalmology department or your med school department or whatever it is, and gets used over and over again. It's certainly well within a price range that makes sense.
I think so.
Although I was actually also impressed that there were no conflicts of interest by the authors.
Yeah,
it was not sponsored.
Great.
So it's always nice to see unsponsored research of these kind of medical devices.
Definitely.
Great. All right. Well, that's all we've got for today. Thank you for joining us. Of course, join us next week. Again, we should be here Tuesday at 3 p.m. Central again. Read these papers and more at JAMAnetworkOpen.com. Everything is free and open access. Follow us on the usual social media channels. And feel free to send us your thoughts or comments or questions.
Thanks so much, everyone.
Great.
Bye.
Take care.